So if you didn't know, I'm Raj. I'm one of the second years. Um, I'm an avid climber. So I thought for my wilderness talk, I would talk a little bit about climbing injuries. And I don't mean like popping tendons and stuff, like more in like the traumatic injuries in climbing. Um, so why does this matter? Oh, and also I put vacation photos in there just to keep it interesting. Um, from a personal perspective, I'm very fortunate not to know anybody who's died in a climbing injury, but I'm like 1 degree of separation away from numerous. Was that? Oh yeah. Yeah. So from a personal perspective, I know numerous people who have been critically injured in climbing incidents. And I think that's because, especially in the high alpine, climbing injuries are often catastrophic. Um, Probably because usually they're involving cliffs. The most common cause of a fall, or rather, the most common cause of injury in multiple trauma or like severe trauma, is from falls, usually with a median height of at least 17 meters. So these are people getting very injured. Falls on snow and ice are often more severe, I think, from numerous different reasons. One of them is when people fall on snow, they often pick up a lot of speed and then fall into a crevasse or something going at 50 miles an hour. Rock fall is also a common injury. So, gonna try not to just lecture at you guys too much, but just a discussion of why we would care. The other thing is because it's usually involving cliffs and steep terrain, you can expect that extrications and rescue efforts are going to be slow and logistical nightmares. I looked at a registry of like mountain accidents internationally, and 40 to 50% of them required the rescue team themselves to be belayed at one or multiple times. So that's requiring additional people, that's hauling tons of extra gear, really slowing down the rescue effort. So things to think about. And then 95% of rescue incidents actually required helicopter support. Yeah. Yeah. So belaying is basically you put somebody on a rope. They have to be like with a harness, and somebody has to kind of just like protect them and lower them down or raise them up with the rope. So again, requiring extra gear, extra people. It's going to be just a quick talk, honestly, nothing too in depth. So I figured we'd just do a case. Setting the scene, search and rescue is notified of a 28-year-old male who was injured in the high alpine by rockfall. Per the message they received by his climbing partners, emergency beacon, the patient is unresponsive and barely breathing. You are responding by helicopter and you're dropped at a clearing like 45 minutes below where they're located. This is pretty realistic. Another thing that often happens is maybe a helicopter support will be getting coordinated while a team will hike from several hours below where a patient is injured, maybe from the base of a mountain. So just off the top of that, can anybody think about maybe some concerns we're having here, just from the EMS note you're getting, basically? So you can imagine it's a great question. Yeah. So I mean, depending on where you are in the world, it might be different people, but usually it's paramedics, search and rescue. Sometimes it's a combination of wilderness EMTs, and maybe there'll be a medic hiking in later. But for the purposes of this, we can imagine that people have at least like paramedic level training. If not, it's just you if you're wilderness medi. Okay. Anybody have any other thoughts just based on like the dispatch? Yeah. So I think it's fair to say that unlike the ED, and even I think unlike traditional EMS, in the high alpine, you're going to be encountering areas where the scene will never be truly safe, right? You cannot prevent avalanches from occurring, especially if you're responding to an avalanche. You cannot prevent rockfall from occurring, especially if you're like responding to an injury with rockfall. So careful risk mitigation is extremely important. So we hiking and you locate the patient. You see a young adult male who's lying on the snow and is minimally responsive. His breathing appears very shallow and he's moaning and around him on the slope above and below him. His partner tells you that he was hit in the chest by a large rock, then fell backwards, striking his head into the ground and losing consciousness. So just kind of going through this, what would we do next? One person. ABCs. Okay. No. Also no. Somebody, I heard somebody say maybe, I heard somebody say scene safety as Kelly. So yeah, so I mean, there's giant rocks all above and below this patient. Per like the recommendations from the Wilderness Med Society and various search and rescue societies and mountain society. Actually, the first thing you do is just extricate the patient to a safe location. If you feel safe enough to approach the patient, the thing I would do is extricate the patient. Because what's going to happen if you're doing your ABCs and another boulder comes down and kills you and your partner? You know, it's one of the first principles in EMS and just like pre-hospital response in general is scene safety. So it's very different than how it is when somebody rolls into the trauma bay with severe trauma and maybe they're unresponsive. Very first things you're doing scene safe or not scene safety. So you're doing your ABCs, right? But looking at some algorithms actually that are provided by the Wilderness Medicine Society, before you even check for vital signs, and especially in somebody who is at least showing that they're breathing and stuff, it's recommended that you just focus on extricating the patient before doing a primary survey. So you and your partner put the patient in a scoop stretcher and carry him several hundred feet downhill and station behind a large boulder to assess him. So how should we complete our primary survey? What are the things we're looking at? I think some of you guys called out parts of it we would do. What's the first thing we want to know? Sure. Definitely that's something I want to know. It's part of my circulation. What else do I want to know? Totally. Yeah. Yeah, we're behind the big boulder. We're several hundred feet downhill. No, I mean this is exactly what you would do though, right? You would go to a safe place where if more rockfall occurs, you're probably not going to get killed. So yeah, you would do your ABCs. So we're gonna get some vitals. Vitals are BP 96 over 54. Heart rate is 112. Pulse ox is SpO2 is actually 96%. The patient's breathing 12 times a minute, and his temperature axillary is 91 degrees Fahrenheit. So we do our ABCs first. So airway's open. There's no secretions in it, and he does have a gag reflex. For breathing, he's spontaneously breathing with shallow, quiet breath sounds on auscultation in all fields. And for circulation, he has intact peripheral pulses and seems to be perfusing his extremities. What would we do next? Typically, like if somebody's in the ED, right? They come in, okay, they're like unresponsive, but they're breathing and they have peripheral pulses. What's the next thing we're going to do? Sort of in line with what Kelly said about like identifying things like hemorrhage and other things. What are we going to do next? Expose the patient. Okay, so should we expose the patient here though? Why not? Yeah, so I mean, the patient was found unresponsive in the snow. His body temperature is 91 degrees, and you have a potentially prolonged extrication ahead of you. So this is, I think, a very key difference that I'm glad you guys all immediately saw is that if you take all this patient's clothes off, he's going to get way colder, and you're going to precipitate worse outcomes, not better ones. So, Wilderness Med Society recommends that if you're going to expose the patient, you do it sequentially, one part of the body at a time to limit exposure. There's also some discussion about the utility of actually doing it, or maybe just treating gross injuries that you can see very clearly, as opposed to even exposing the patient at all. So that one, at least when I was doing some literature review and looking at different guidelines, is, I think I would say it's a bit provider specific. Go ahead.
What's the thought process in terms of the patient has left? I mean, it's a difficult, again, exposing someone, what you have, but in terms of something that has to
Yeah. Honestly, that's a great. Yeah, go. What? Oh.
We recently did and the Wilderness Society recommends that we can do the same thing. You can keep the whole but you have to like basically like remove them and certain activities. Most rescuers carry Mylar as a general layer for objective use and for water vulnerability.
Yeah.
And if you have something else to do after, then do that.
And also just for all of you, because I like you all, if you're hiking anywhere where there's a potential for the temperature being below like 50 degrees, like an emergency blanket is tiny, it weighs nothing, well worth.
Mylar plastic.
Yeah, they're tiny. Yeah, and that could save your life. So well worth an investment, and it's like a couple bucks. Okay, so we're debating about exposure. What's next after airway, breathing, circulation in our primary survey? Yeah, so like disability. Patient's Glasgow Coma scale is 7. He really is not opening his eyes to anything. He's moaning incomprehensibly. He does like flex away from painful stimuli, but no other real like clear movements. And then we talked about exposure. So because it's really cold outside and the patient's already hypothermic, you discuss with your partner and you decide that exposing the patient at this time is too risky. Let's just examine for like very overt injuries through his jacket and clothes. So there's no large extremity deformities, but he moans when you push on his left chest. Outside of the patient's helmet is dented on the back, but not broken. So we've done our primary survey. Before we do anything else, what are you guys thinking we should do? What would we do? Maybe just starting, what would we do in the hospital with this exact same patient? Can you say that one more time, Connor? Okay, secure his airway. Why are we securing his airway in this case? Yeah, so does anybody have any other ideas? Oh. I don't think we have a finger stick, but if you're really concerned, you could just rub some glucose gel in his mouth. Yeah, Dr. Palladino?
Just something to think about is securing somebody's airway in this situation brings you more tax.
Go ahead, Kim. Yeah. 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 So in the ED, this person immediately getting to, right? They're like, oh, go ahead.
How are we getting out? Have you called like the providers?
Yeah. So, I mean, in this case, I think we can assume that you guys were dropped off in some remote alpine area by the helicopter, and you can stage back at that clearing you get to and obtain transport out. I think Dr. Palladino and Caleb both bring up a really interesting point, which is that you have one other person who's an unresponsive patient that you have to carry. Probably going to take several hours to carry this patient back to the clearing, given that it took 45 minutes just on foot normally. And who's going to bag the patient if both of you need to carry the patient? So I think in this case, I actually wouldn't intubate this patient simply because intubating the patient, I think, would be akin to requiring further people to show up to help you move the patient. Also, the question of this patient has a gag reflex right now. So in order to intubate them, you would have at a minimum to sedate them a lot more. I think for these different reasons, for a patient who right now, plus or minus, is protecting their airway-ish, they have a gag reflex at least, you may hear signs that their airway is actively becoming compromised. I wouldn't intubate this patient just because that you're not going to be able to carry the patient anymore. Ryan also mentioned concern about does this patient have like flail chest, or would you intubate them, start positive pressure ventilation, and then find that they've gone into like tension physiology. So I mean, that's a great question. Yeah, what would we do about the fact that he has blunt chest trauma based on history and is moaning when you push on the left chest? Is this something we should intervene on right now? Is this something we should maybe wait to intervene on? It is totally a provider call, by the way. I think it could go either way on this one.
Morphine if you have.
Definitely morphine if you have. I think, yeah, so for this patient, I think there's an argument that probably examining the chest and considering needle decompression and then the application of an occlusive dressing, that you could bleed out if needed, if like air seemed to be accumulating. I think that's a reasonable option. I think there's also the other option of, yes, the patient has a soft blood pressure, they're tachycardic, that might be secondary to pain for the tachycardia, but their MAP it's okay. It's above 65 right now. You maybe could just consider monitoring the patient before intervening. I think it's maybe more of a judgment call on that one. So, our outcomes. So you place an IV, you administer 8 milligrams of morphine, and you start a liter of LR. Then you load the patient back into the scoop stretcher and extricate him to the clearing where the helicopter can pick you up. Once in the clearing, you intubate the patient. And in the helicopter, you expose the patient further and examine the left chest. There's a crepitus on the left chest, and knowing that at altitude, particularly the altitude the helicopter is going to reach, the pneumothorax may worsen because the volume of gases will expand at altitude. At that point, you decide to put in a chest tube to ensure continued stability. So you put in a pigtail, helicopter takes off, brings the patient to a trauma center, patient survives. What are some thoughts about the interventions that I at least chose to do? Because I know we have several people who know a lot about wilderness med. I know we have a lot of people who hike. And I think there were some judgment calls that truly might be provider specific. We gave a lot of morphine. Other good analgesic options that I see being used are ketamine. I think previously sometimes like inhaled anesthetics were considered. They have interesting interactions at high altitude where for some of them the efficacy is kind of blunted and you need to give more, but then you see all sorts of weird things happening when nitrous oxide is used. I also don't think personally we have a ton of experience currently with inhaled anesthetics anymore. So it's not something I would personally use. this is just a general flow chart about like how we should go about things. So if you can see, this is straight from the Wilderness Med Society. Um, First thing you do, check scene to safety. Is the scene safe for rescuers? If there are imminent major hazards, you can see on the floor chart, before even looking at vital signs, you extricate the patient to a safe location. I guess that was one of the biggest learning points I wanted you guys to take away from this, which is just like, if you're coordinating response, if you're the one responding, or you just like are hiking and you pull up on scene of something, get to a safe location before doing anything. I'm not going to go through this, but this is just kind of a escalation of pain. Oh, well, whatever. There's just escalation of pain. Psychological first aid is really, really helpful. These patients are terrified, they're in pain. Talking to them, assuring them that they've gotten help. These things can go a huge way. Non-pharmacologic interventions should not be underappreciated. Things like splinting, ice packs, etc. They have real value. Then something.
Ketamine in the helicopter only because it uses them a lot, and if he's starting to come up and not be under, you may get very, very violent in the helicopter.
Yeah.
Emergency helicopter is very difficult to deal with. I'd rather something that knocks them down than they confuse. I probably would not keep ketamine for this.
I think that's fair. I think I would agree with that. I think usually I see it being administered on scene, like in lower doses. Though, interestingly, I read a cool case report about ketamine being used as a analgesic in Nepal at like 4,600 meters. And they found that like 0.5 mg per kg just completely made the patient apneic. And so something to be aware of if you ever find yourself like working at like Everest Base Camp, that maybe there's some, should very carefully titrate up these medications because weird outcomes have been observed. Caleb, you had a question? Yeah. No, I totally agree with you. I mean, this is a great point, and I think that is the main thing we're concerned about with giving IV opioids or just opioids in general, is that they have well studied outcomes, both like intended analgesic outcomes and side effects. But very known respiratory suppression. Yeah, I mean, well, for in this case, you can't take Tylenol. If you had like ketorolac or something, you could give it. No, I agree with you. And I don't have a great answer beyond just like, maybe you could be seeing, hey, is his heart rate because he's in shock, or is his heart rate because he's in pain? Yeah, go ahead.
To comment on, can you comment on like role of blood, like pre-hospital, like because this guy's already in stage.
Yeah.
Shock, right?
Yeah.
Vital signs arrangement and for long execution, like he needs blood. He wants to survive.
Yeah. So all the studies that I looked at regarding like blood administration, and I'm sure there are studies I didn't manage to look at that looked at in the field administration of blood. I think probably out of the military, this is much more heavily studied. Most of what I was seeing was saying that if we go back to our kind of flow chart, that immediate safe location when you're behind the boulder, right? You're like, you're kind of safe, but you're still far away from actual resources. Usually I was seeing things like IV fluids started, basic stabilization, like needle decompression if necessary, things of that nature. And then I was seeing like when you get to a more area where you can stage and wait for transport, that was when I was seeing things like blood products being used. So I definitely think there is a role for them. I don't know if they're as commonly used like in like a medic bag, for
Some
instance.
stuff I've read has been EMS and not airlift, just because there's a lot of logistics in keeping it cold, switching it out so it doesn't expire, and like, it's just really, really difficult to keep blood at the right temperature and use it for people. But most of the stuff I read has been ambulances and not airlift.
Go ahead.
A lot of what I've looked into in regards to EMS. Blood banks that my kidney, for example, because they don't have their own blood bank.
Go ahead.
Yeah, so a lot of things mentioned and touched on. So I'll just go backwards from Sydney. Sydney's looking at it. They're actually looking at dropping drones at the point of injury using DJI drones.
That's fire.
Like that. Right, I'm working with them. We're actually making lanes from hospital to hospital. There's another kind of like large disaster, the bridges are either clogged off or out or something. There might be drone specific lanes that will just go from our blood bank to Bellevue. So just kind of run this bus path of bringing blood back and forth. I could bring it to this point. As far as this goes, if you're working with like a large rescue team that has logistics like access to blood banks, like military and things like that, they will give blood at the point of injury because there's a difference between logistics and patient outcomes. What I can carry is what I can carry. Does it help the patient? Not necessarily, but it's what I can carry as a hiker. And it works the other way too. I can carry it, but just because I carry it doesn't help the patient. So if you're going to give somebody blood, it has to be within 30 minutes to affect mortality. So if mortality is what you're worried about, then it's got to be within 30 minutes, and that might be at the point of injury. In terms of the anesthesia, what we worked out is we just put morphine out of our. We would give them ketamine. And we do put them on helicopters ketamine, but we have the ability to give them first head if they start to get out of it. And we have like thousands of patients that we medevac on in our helicopters. And we don't really have those problems because we're usually giving them a dose that's close to RSI. So somewhere like 2 milligrams per kilogram. The 0.5 milligram per kilogram where they became apnea could have something to do with high altitude, maybe have high altitude pulmonary edema.
Yep.
Maybe it got slammed fast, but it's definitely a case report. They usually don't become apnea with such little doses. That's an analgesia dose, not
Yep.
an RSI dose.
Yeah. So I mean, you bring up a great point, which I meant to talk about and I forgot to, but many of these patients, they probably got injured often descending from routes when they're extremely tired. They may have other things. They may very well have high altitude pulmonary edema. They may have acute mountain sickness. They very likely may have an other potentially contributory medical issue going on in addition to their trauma, which can complicate things pretty significantly.
To touch on the airway and the other things is what we would do is we might not even start a line. I mean, we would start a line to have a helicopter nearby, but if I don't, I have to hike out of there. We've gone through the woods and forests with IV lines.
It's not great.
So I would just give them intranasal atomizer, intranasal. I don't have to start an IV. I don't have to bother with an IM. It's really quick to do, and then we would just crack them. Because a cracked patient can breathe on their own. I don't need to bag them. I can bag them if I need to, but I don't need to bag them. Keep their airway.
So you would,
if they get worse and you're over there, I know it's a terrible thing to say, but don't forget the time and the feel.
yeah. So you would crank them like in the field and then extricate fully.
Yeah. There.
Yeah. That's pretty badass. I'm not gonna lie. Gotcha. Any other questions? No. Okay. Oh, go ahead.
As you read that research, was there any, I know there's also like the mark algorithm that people use as well. Was there any like comparison? This is like the march, which looks at like massive coverage curves and kind of
Honestly, I didn't see any. I'm not saying that there's not. I would say that there's, I mean, some of our other attendings may be able to talk more on that, but usually, at least for climbing, when I was looking specifically for climbing injuries, it's not so much penetrating trauma. I mean, there definitely is often massive internal bleeding, but it's usually more like blunt trauma in general. So I didn't see much discussion of that. No, couldn't be. All right, thank you guys.